Dr. Tagan told me that he's wearing a Kevlar vest, so he's happy to take questions. Yes.
Well, I had something that relates to myths, but it wasn't your myths. But I'm a little concerned because several people have spoken to me about a statistic that was quoted early, and I apologize because I do not remember the speaker that quoted it. But it was regarding risk of developing lymphedema, and it was stating that women who had reconstruction were like 20-some% less likely to develop lymphedema. I want to be very careful about walking away and telling our patients that, because although I don't know the study, my guess would be that that was not a randomized group of people who chose to have reconstruction or not. I'm sure there was medical advice involved there, because the patients I see who don't get reconstruction, yes, some of them choose not to, but many of them it's because they had radiation or advanced disease or something that made it impossible for them to have reconstruction. And I would expect that, of course, those people would be more likely to develop lymphedema. So I just, so I think that's skewed, and I don't think we should just walk away thinking that. So it's not your, it's not your myth, but I want to make sure we don't perpetuate that.
It's actually one of the studies is my study, so I can talk about it.
Oh, good.
So within our screening program, within all these databases, is this working? So one of the people in my team told me, can we look at reconstruction? And we thought it's actually the opposite way. Maybe women who undergo reconstruction might have more lymphedema. Let's look at these cohorts. So we found 600 women. Some of them had reconstruction. 25% did not have reconstruction. And reconstruction, we are very much at Mass General an implant school. Like we do less TRAM and autologous. And we looked at the data. We found that women who did not have reconstruction had a very significant risk of lymphedema. And we did a multivariate analysis to control for advanced disease, etc. And we were afraid of publishing this. We kept it in my desk for a little while because just surgeon told me, no way, no way. Until I looked at the literature and I found that MD Anderson found the same thing, Memorial Sloan Kettering, they found the same thing, and a group from South Korea found the same thing, but their way of measuring lymphedema was not as accurate, as neat as our system. And then when they say, hey, everybody is finding that, I'm going to publish it then. So and then I published it. And I had only 600 patients. Now, I wanted to update this data with more than 1,000 women with 1,400 breasts. And I found the same thing. It's very solid. We can find an explanation. There are a lot of explanations. But yes, women who don't undergo immediate reconstruction, taking in consideration all the other factors, they are at significant risk of developing lymphedema. That's what the data says.
Okay, good. I'm glad I asked.
And you counted, obviously, for stage of disease. Did you account for number of lymph nodes removed, or maybe other factors like perhaps type of chemotherapy used? I'm not sure, because it seems to me, that there's the women who don't get reconstruction, either they choose not to, but maybe the more likely reason is because they have such advanced cancer, and so therefore, they're not necessarily candidates. Perhaps some of them are even stage 4 patients. So I'm assuming you control for stage, but how about other things like the number of lymph nodes and the chemotherapy used, perhaps?
We accounted for everything, because we really wanted to know, and just that's what we found at the end. Mm-hmm. Yeah.
Any thoughts on why?
Any thoughts on why?
Why they would have that?
Yeah, I think like my colleague Cheryl mentioned yesterday, some of the things that I read and I also discussed with our surgeons, maybe when there is no reconstruction, just the surgeon take a large piece of skin and you take with it a lot of the lymphatics. That's one explanation. Another one, when you have the skin really sitting on the chest wall, maybe more fibrosis, more obstruction of the lymphatics. Maybe when you are reconstructing the breast, you stimulate some angiogenesis and lymphangiogenosis. So there are a lot of things like that. But we have a bunch of very prominent plastic surgeons here. They can probably tell us. They can try to find an explanation, but that's what the explanation is given. But it's significant.